Afternoon to all of you, and it's a pleasure for me to be here. I'm Dr. Raki Maiwal. I'm a professor of hepatology, and I'm looking after as in charge of the intensive care unit at the Institute of Liver and Biliary Sciences at New Delhi. And it's an immense pleasure for us, and I'm flanked by my colleague, Dr. Kavish. So, Dr. Kavish.
Yeah, great to be here. Thank you, Raki. Kavish Patidar. I'm Associate Professor of Medicine at Houston Methodist Hospital. I'm also the Associate Clinical Director for Academic Hepatology for in terms of research. And I'm excited to be here with you to talk all about AKI in cirrhosis in 2026.
Actually, I would say, Kavish, it has been a pleasure for us to be working together, specifically understanding AKI in patients with liver disease and understanding the complexity and the way the field has been evolving. We've seen how much change is happening every year in the understanding of the AKI, and that is where, because we know that if you're able to improve the kidney outcomes, it is indirectly related to improving the liver outcomes. So that is why this becomes very important. So what we are here to discuss is about the evolution in the understanding of the HRS AKI. So would you like to comment on how our understanding of HRS AKI has evolved over the years?
Yeah, so I mean, I think the first thing is, over time, the patient population is changing. So we're seeing older patients, we're seeing more comorbid issues. So the way we approach AKI and HRS AKI has evolved with it. So traditionally, we thought of no comorbid conditions, patient with ascites and cirrhosis, but now we have to factor in so many other things when it comes to diagnosing HRS AKI. And I think, from my personal opinion, I think we're making it simpler. I think making it simpler for practicing clinicians is a good thing because it potentially could lead to better outcomes. But it's still hard to diagnose HRS AKI. Regardless of where you are, I personally still think it's never a clear-cut thing.
Yeah. So can we make it very simple? So when to suspect HRS AKI? So as a group in the consensus panel that we had proposed, so we made it very simple, irrespective of the creatinine, irrespective of the clinical status, and even in the presence of background CKD, like you rightly mentioned about that CKD can be there in most of these patients, so it is not purely functional. So what are your comments on that?
I completely agree with that. I think it's the older criteria will have no proteinuria, no hematuria, et cetera, but a lot of our patients now have diabetes, they have underlying CKD even before cirrhosis happens. So I mean, we cannot say that they don't have HRS AKI. So I think the guidance statements made a good call in terms of not excluding these patients to make the diagnosis, because by doing that, we could be, causing harm to that patient by not providing them adequate treatment.
Of course. So this is one important point. The other context is where we were not diagnosing HRS was in the background of tubular injury, acute tubular injury, which could be particularly in patients who are deeply jaundiced, or what we call as acute and on chronic liver failure, where systemic inflammation, deep jaundice, bile acids are contributing. So we are now recognizing that there is a phenotype of AKI called as the cholemic AKI, which can be having some form of tubular injury, but it is distinct as compared to acute tubular injury or acute tubular necrosis. So what are your thoughts on not taking out again the phenotype of some form of tubular injury in diagnosing HRS AKI?
So this is a tough one, Rocky. Everything's never going to be black or white. There's always going to be a mixture of things. I think the most important part as a clinician is to figure out what's the driving factor. Especially learning from your work, I think coulommic nephropathy is under-recognized. I think we're now becoming more familiar with it. And if you think that's the driving force, then perhaps focusing your treatment on that for that injury. But if we're in the context of HRS AKI and you have some coulommic nephropathy, I guess the next question is what to do next. Are we going to start vasoconstrictors or focus more on the coulommic part? And I have a question for you and what you would do.
Yeah.
And how would you, for somebody that is not now recognizing this is an important entity, how would you diagnose coulommic nephropathy?
So the clinical diagnosis of coulommic nephropathy is very difficult because we may start suspecting first is. So in the context of HRS AKI, specifically what we say as the apostle definition of acute on chronic liver failure. So again, there the definition of ACLF which we're using to define the syndrome of ACLF will matter, because what we see coulommic nephropathy is less likely to occur in patients who are decompensated cirrhosis with jaundice or with sepsis. So it is more likely to happen in our experience in patients who have ACLF, where bilirubin and INR and then the liver failure is driving the renal dysfunction. So it occurs in the context of severe systemic inflammation, severely jaundiced patients. And the other important point in the clinical diagnosis of coulommic is that when you have to differentiate it from HRS, the important point is that these may have some form of circulatory dysfunction, because bile acids are known to cause some form of circulatory dysfunction. So they may have some circulatory dysfunction. Terlipressin response is also better as against the acute tubular necrosis, but we should never be giving terlipressin in ATN patients. So that is one way to make that diagnosis is very important, because it can be harmful, terlipressin. But in coulommic nephropathy, even despite tubular injury, the response to terlipressin may just be partial. So it will improve the circulatory dysfunction, but you will have to do a strategy to counteract the inflammation, or you have to counteract the severe jaundiced bile acids if we are measuring. We do not know whether it is harmful or not, but these are the indirect surrogates in the clinical practice that we can see. So for me, if the patient has a severe coulommic nephropathy where the patient has already gone into stage 3 and the patient is having high creatinine, so obviously for circulatory dysfunction, and patients usually are non-oliguric, you will see some response, so a partial response to terlipressin, and then you should add your strategies like CRRT in patients who have already, there is a risk of getting pulmonary dysfunction with plasma exchange or therapies or adsorption modality. So those adsorption strategies, and CRRT is the most easily available therapy that can be offered, and it should be initiated early in these patients at the partial response.
That's a wonderful observation. So the key things I'm hearing for coulommic nephropathy, it's more likely in ACLF, unlikely in very progressive decompensated cirrhosis. These patients are oliguric, they're not anuric, and they may respond to terlipressin. Yes. So that's a good way of differentiating if this is ischemic tubular injury versus tubular ATI from bile acids. So I mean, I think that's a really great point. So essentially, we should not be withholding vasoconstrictors in the patient with suspected coulommic nephropathy superimposed with HRS AKI. That's wonderful. The other thing I wanted to ask you about is in coulommic nephropathy, oftentimes if someone's just jaundiced, you can have this bile stain hyaline casts. How do you differentiate in your analysis that this is? I mean, I know you're not a nephrologist, but you know everything. So one of the things that my nephrologists tell me that are hard to differentiate, if this is hyaline stained bile or is it truly bile casts?
Yeah. So that's another very important point. So therefore, like we are saying that AKI has to be diagnosed in a clinical, like you need a lot of things to support what you're seeing on the urine microscopy is actually bilirubin stained hyaline cast. So that is what I'm saying. So there may be HRS, so coulommic may coexist rather being a tubular injury, but it is likely to behave like HRS. We will diagnose clinically more as HRS rather than ATN. But these are the factors which will determine that, okay, these patients will just not respond clearly to your terlipressin and you need to do more. So that is where the distinction from HRS comes, and that is where the distinction from ATN is important for us to differentiate. And for like we've done this work, and most likely if we get that in the publication, so it is what we have shown is when we are looking at the different biomarkers of inflammation. So we found that glutathione S transferase levels, and in the initial postmortem kidney biopsy data also we showed that like for the sepsis concept, that is it is the host response. So in colemic, it is the kidney response to your systemic inflammation. So the tubules respond, so by there is a preservation of the mitochondrial function. At the tubular level, we've seen that. So markers of mitochondrial function can be very important to make that clinical. So using biomarkers not of renal tubular injury. So what we found was NGAL, which is a marker of direct tubular injury, was intermediate high because of the systemic inflammation. It is not very high as an ATN. So it was intermediate, but HRS patients do not have NGAL to be high. So what is a specific biomarker? We found glutathione S transferase to be becoming as a very important. And apart from the inflammatory cytokines that we found in that work was IL-15, IL-3, which was important, and we also found serum bile acid. So even if you're not looking at the urine microscopy, these are the panel that we're proposing, and maybe future we should look at parameters of mitochondrial function, which will be very important.
That's very interesting. So, you know, with ATN, we can have G1 cell cycle arrest, what, you know, eventually can lead to damage. You know, for a busy practicing clinician, you know, it's hard to do, you know, or asking your colleague who's a nephrologist to look at the urine. Did you find differences in urinary sodium or fractional excretion of sodium? Does that even matter in this context?
Yeah. So we see urine spot sodium. So that is where you were also making a point in morning discussion that in colemic, the urine spot sodium is again, it meets the HRS criteria. And we do see in colemic some tubular epithelial cells because there is some form of tubular injury specifically, and this can be driven by also the clinical context of the patient, because we see that there are multitude of factors which are affecting the kidney. But when we are highlighting the pure phenotype of colemic, this is what we see. But in real life scenario, we are not seeing, maybe this is only a fraction of patients that we see pure colemic, pure ATN. So many a times we do see both things together, bile cast and ATN. So mixed phenotype is also very commonly seen in clinical picture. So that is where it is. But when I'm saying all this, I'm purely saying I've selected out the pure clinically phenotyped patients and how we distinctly make that diagnosis.
I see. Now I'm going to reverse back to the initial management because, you know, I have some questions because, you know, it's not every day you get an author on the consensus guidelines. You know, on the consensus guidelines, you know, I certainly do agree, you know, the 48-hour rule is arbitrary. You know, we don't really know. But I think one of the key things in the guidance statements that I could not really comprehend is that there was an actual example of how much fluid to give. You know, I think it was 500 cc's. That's minimal to you know, to say that, you know, how much fluid we should be giving. I mean, this is for crystalloids, and it was, you know, again, less than a liter. I remember looking at it and I thought to myself, this is nothing. You know, and you may not be that person in that section, but in your eyes, you know, if you didn't have all the tools available, you didn't have POCUS, you didn't have biomarkers, you think somebody's intravascular depleted yet extravascularly volume overloaded, how much is too much? How would you assess that their volume down based on your experience, and how much to give, and how do you assess on each time period? Do you assess every 6 hours, every 4 hours? Is urine output a key thing here for you?
So when we're talking about these patients where you're saying that, so most likely these patients are in shock and also have severe AKI. So as I understand, if we're talking about that phenotype of patients, because here the 500 ml, like what you're saying, is very less. So an appropriate fluid challenge for a crystalloid, for a critically ill patient who's in shock, and has organ dysfunction is around 30 ml per kg. But in cirrhotics, because we are concerned about fluid overload and that's problems, so ideally we usually, if we are giving a crystalloid challenge, we give 15 to 20 ml per kilo. So it's around 1.5 to 2 liters. And we give it, if the patient is in severe shock, we give it rapidly over 30 minutes. And if the patient is stable blood pressures, but yes, the patient has shock and a stable dose of norepinephrine, I will split it up into 3 hours time. But I will give an appropriate dose of crystalloid if I'm giving. If I have to give a colloid, that is where it becomes important that if I have to give a colloid challenge, and that is what we showed in the FRISK protocol, that 5% albumin, if we can use that, 255 ml per kilo for a patient, is a very good colloid response that we can see in a sepsis-induced hypertension. In the patients who are actually, the AKI is not in the context of shock and are in the wards. So in that setting, I would say that if the patient has stable mean arterial pressure but has severe AKI, so single organ failure is AKI but stable hemodynamics, I would combine my slow infusion of crystalloid, so maybe 500 ml with albumin, and wait for another 6 to 8 hours. Where we have the luxury of doing these POCUS and we have experts, and because obviously we cannot do and we are not doing everywhere. If you have lot of patients and the residents on the floor for us, it sometimes becomes difficult. So this is how we look at the response to the volume expansion, and that initial assessment of looking at your lung fields before starting that volume expansion becomes very important. The clinical history, if you're dealing with septic shock, which is in the late phase where a fluid challenge can be disastrous, versus a pre-renal ATN, early phase of septic shock. So all that differentiation will come by a good history and at least lung assessment and cardiac assessment and the background history of comorbid diseases will be very important.
Yeah, I think that's a great point. You know, I think at least in the U.S. perspective, we get scared of using crystalloids, and we are, you know, because traditionally we've been taught albumin, and based on your trial, it is helpful, it works, but it didn't improve 28-day mortality, correct?
Yeah.
But it improved renal recovery. So I think it's being nuanced, and if you're long, I think the moral of the story is giving the amount of volume, and combining with some form of colloid might be the best way moving forward. Certainly the POCUS is hard. So say you're not in the ICU setting, capturing urine output on the floor to assess if someone is responding is inaccurate. One of the challenges I have as a clinician is serum creatinine can lag behind. Yeah, so and so this is where the debate comes of the 24 to 48 hours. The traditional, the original writers, had this in mind when they wrote that, and giving it enough time to actually measure the creatinine. But do you think 24 hours is an adequate time period
for
to assess for response? Yeah.
Yes, of course. So I feel that is where Kavish, you would agree that the volume assessment, the mean arterial pressure, urine output, like you said, and don't wait for your creatinine. So creatinine at 24 hours will give us the information, but whether that creatinine will give us the necessary information, we'll get with all these surrogates, the indirect surrogates. The rapid increase in urine output will not happen, but yes, if the urine output is dropping, I know, and my MAP is not improving, my mean arterial pressure is what will drive the kidney outcomes. So that I know the fluids have to be given more, or whatever, to wait for your next day creatinine to give you the picture. So these are the 3 things which I will keep doing in that 24 hours, and obviously I will wait for the creatinine result at 24 hours to guide the subsequent course of management. Yeah,
I mean, I think that's a great point. I mean, you can look at your MAP, if they're truly hypovolemic, you should see an increase in MAP, the urine output should increase, and the patient actually will tell you that. And perhaps cystatin C will make its way into the new guidance, because the kinetics for cystatin C are a little different, and they may give us a different story in terms of timing of therapy, particularly because at this point, at this juncture, the biggest concern is, do we give vasoconstrictors or not? What's your experience of, and have you used cystatin C for determining response?
Totally agreed. So in the ICU context, where we are looking more at tubular problems, I would use NGAL. There I don't use cystatin C. But even in an ICU context or in a ward context where you have patients with refractory ascites, refractory hydrothoraces, you will see your creatinine because these patients are sarcopenic, or if they have come with NSARCA. So you know your creatinine may be just 1 or 1.2, but the patient may have a severe AKI. So this is where I feel cystatin C measurement becomes very, very important. And in our practice, we've seen a cystatin C cutoff of above 2, and in the critically ill patients above 3 or 3.5. We know despite a normal creatinine, we are dealing with a very severe phenotype of AKI, which may be HRS AKI phenotype, which is very severe, and where the thing comes where the HRS progresses to ATN. So that thing which we see with immensely decreased GFR, where we don't see the urine output. The urine output becomes very important in that set of patients.
Do you find it useful to repeat the cystatin C as you're giving therapy?
Yeah.
And so comparing that delta with creatinine, are you seeing a faster change with cystatin C with the kinetics?
Cystatin C kinetics is better, but only problem for us to get cystatin C is the results of cystatin C we don't get so early like we get for NGAL, but we get it in 24 hours. So that is the only problem with cystatin C repeated measures. Otherwise, we do see cystatin C to be a reliable marker in this set of patients where there is no inflammation but severe and a slow phenotype, insidious onset, like we say AKD or phenotypes of CKD in refractory ascites and that set of patients.
That's great. Well, I mean, I think, I don't know about the audience, but I've learned a lot from Dr. Mewal, you know, so I mean, this is fantastic. So I think moving forward, at least in my eyes, where the field should move forward is, how do we personalize therapy? We can't use a one-size-fits all. How do we incorporate biomarkers? Because I think, NGAL, there have been multiple studies. You've published multiple studies on this. I think it's ready for prime time. I think it's time for the next step. I think it's time for the community to really highlight this in a guidance statement, because there's enough. And this is probably the one thing on the guidance that we can have actually be evidence-based about. Everything else is expert opinion. So this is the next step I think we should be going towards, because I am a believer of POCUS, but as you mentioned, in a busy ward, when you're seeing 50, 60 patients, it's and 30% or more will have AKI. It'll be very hard to do a POCUS exam on everybody. So I think the next, in my eyes, the future is going to be biomarker-based, where we have a troponin for AKI and cirrhosis, and if it's this level combined, and it may not just be one biomarker, it may be combination of biomarkers, and that way we can personalize and streamline therapy quicker. Like, for example, you had discovered biomarkers for coulombic nephropathy, and combining that with something else may give us a better idea in terms of prognosis and therapy and responses to therapy. What are your thoughts? Is that you think?
Yeah, of course, I totally agree. And so wherever we can do these things, it is like we make it simple. But I feel whenever we are suspecting a severe AKI, it is very important that we stop saying that we do simple things. It's better to do a multimodal assessment, because a severe AKI will have very bad outcomes even for liver transplant. So it's important, and I feel for me in the ICU, when I'm managing these sick patients, I feel that my only challenge is how to preserve my urine output throughout the length of the ICU stay, because that is what will give me a very good outcome totally with respect to my medical therapeutic management, and also if I'm planning a transplant. And that is where that urine output becomes very important in a sick cirrhotic.
And that's a great point, because if you look at the original, the 2015 guidelines, they specifically mentioned that these patients are sodium avid and they're going to have decreased urine output at baseline. Yeah. But that's not the case. Studies have shown, like in a large ICU study and based in the US, your studies, that urine output is a good metric.
And I'll tell you, we had I don't know about US, but in India, so in our ICU, it was a lot of struggle to move to that concept that don't wait for the complete, that is where we are proposing early CRRT. So we start CRRT, we don't wait for the urine output to shut down. And in our trial that we completed of 50 patients on early versus late initiation, the two important predictors of good outcomes with CRRT was the lack of oliguria. So if we have started CRRT and the urine output has not gone to the oliguric phase, those were the patients who were also responding well to the treatment. So that concept has again evolved, and we had a struggle debating with the nephrologist that we don't need to wait for the urine output to crash to start CRRT or the hemodynamics to drop to start CRRT. It should be started when we are assessing our therapeutic strategies have failed. We start CRRT on time to get the best outcomes for the kidneys.
And these are patients with ACLF,
These are
severe,
patients with ACLF
severe
who just
AKI.
rapidly go down.
Okay.
So 4 days become important in the ICU because you have to make the organs better and consider a liver transplant.
And that's an important point because the trials for early versus delayed CRRT, most of the patients, there was a small fraction of patients with cirrhosis,
with
liver disease. They didn't, it wasn't even graded in terms
yeah.
of how severe the liver disease. So I think that's an important point. And you know, starting CRRT, you can manage the hemodynamics better. And then who knows at that point if that, you know, they probably had intrinsic injury, maybe the better choice at that point if they're that sick.
So I think so we had a wonderful discussion and looking at the perspectives from a country like ours and from a US perspective. So, but we understand that globally the think tank is moving together and we're trying to understand how to stratify AKI, how to make the assessments better. And it's okay. I think so we had a lot of discussion about what we are bringing up, new concepts, and I feel our viewers and would be benefited with this conversation. Thank you.
Thank you. Thanks for having me, Rocky.